Okay, it is 11:10, and I was told also I have to go very fast because I am the last talk before lunchtime. It is a pleasure, though, to be here. Thank you very much for inviting me. Again, as I said before, it is such an honor and privilege to kind of be a part of this, but also more importantly to see how this meeting has continued to be such an important part of the the Taiwan education community. So it's always a pleasure to come back. So my talk is on updates in the radiotherapeutic management of rectal cancer, liver cancer, two topics that aren't that related, but this was the topic I was given, and some of it will be a bit of a review of some of the literature, but then in the liver section there'll be some discussion about some of the work that we've done at Michigan. Let's see, here are my disclosures. And so the first section will be on rectal cancer treatment, and there are really three topics I want to touch on. Total neoadjuvant therapy, non-operative management, and then the use of chemotherapy or systemic therapy alone. Just to kind of update and level set where we are, but for background, rectal cancer is one of these disease sites that has really undergone a huge metamorphosis over the last many decades, but particularly just in the last 5 years or so. But you could see where we came from, where really we had high distant and local failure rates, and then over the decades with the advent of using radiation and incorporating chemotherapy, and with the addition of oxaliplatin and multi-agent chemotherapy, you can see that we've been able to get local control rates to be extremely high. So local failure rates are down in the single-digit range, and distant metastases continues to be the primary pattern of failure. And so where we are and how the treatments have transformed over those years, you can see back in the 80s, we were primarily using adjuvant therapy. There was the NIH consensus statement in 1990. The German rectal trial came around kind of in the late 90s, early 2000s, that really established preoperative chemoradiation as a standard of care, where it lasted for about maybe a decade and a half or so, and really kind of starting around the late 2010s, total neoadjuvant therapy became sort of the new standard of care. And so the rationale for total neoadjuvant therapy, distant failures are now more common than local failures, as was shown before. Many patients do not receive or complete adjuvant chemotherapy, which is really the treatment that you need to address metastatic disease. And because they usually have a lot of toxicity, complications, morbidity after the surgery, a lot of them cannot complete the adjuvant chemotherapy. And a lot of adjuvant chemotherapy trials fail to show a benefit. And primarily because you won't actually get benefit from chemotherapy if you're not able to actually get the chemotherapy, right? So moving the chemotherapy into the preoperative setting that addresses the potential for early systemic failure and also be able to get more treatment in. So the role of radiation in total neoadjuvant therapy is predominantly to continue to keep the risk of local recurrence low and increasing the potential for organ preservation, which we'll talk about next after this. Just to review the trials that really established total neoadjuvant therapy as a standard of care. The RAPIDO trial was, I think, the first randomized trial to really test this and show. This was a phase 3 randomized trial, randomizing patients to standard of care short course, 5 grade times 5, followed then by chemotherapy and then surgery. So this was the TNT arm, the experimental arm was short course chemo and then surgery, and then the standard of care arm was long course chemoradiation with concurrent capecitabine, followed by surgery and then adjuvant chemo. You can see actually that patients in this trial were pretty locally advanced. About a third of patients were clinical T4. And what they showed was that the 3-year disease-related treatment failure rate was lower with total neoadjuvant therapy. That was statistically significant, as was the 3-year distant metastatic disease rate, which was statistically better. And there was no difference in 3-year local regional failure rates. So, to summarize, the short course total neoadjuvant therapy arm led to improved 3-year composite primary endpoint of largely due to decreased distant metastases. It actually showed improved pathologic complete response rate, doubling from 14% up to 28%, more pathologic downstaging, fewer grade 3 or higher adverse effects, and no difference in R0 resection, sphincter preservation, local regional failure, 3-year overall survival. And the 5-year update actually did show that there was increase, though, in the 5-year local recurrence rate, particularly with short course radiotherapy. So this was kind of an interesting little wrinkle that suggests that perhaps short course radiotherapy may not be the best treatment option. The PRODIGE 23 trial was the next one. It was a phase 3 randomized trial randomizing patients to either a total neoadjuvant therapy of modified FOLFIRINOX, followed then by long course chemoradiations and then surgery and adjuvant chemo, or standard of care chemoradiation, and then surgery, and then adjuvant chemo. Primary endpoint was 3-year disease-free survival. And from this table, really the main take-home points was that there was an improvement in the percent of patients on pre-op CT with metastatic disease that was reduced with the TNT arm, improvement in 3-year disease-free survival, 76% versus 69%, improvement again in pathologic complete response rate with TNT, improvement in overall response rate or pathologic response rate, and then as well as decrease in grade 3 or higher adverse events. So summary was neoadjuvant TNT or modified FOLFIRINOX with chemoradiation provides improvement in path-CR, disease-free survival, and cause-specific survival. And then 7-year update that was presented at ASCO in 2023, there was now an improvement in overall survival as well. This is a trial also using TNT, but it was actually testing the sequence. As you saw in the previous trials, one had radiation first and then chemo, and then the other had chemotherapy followed by radiation. So that has kind of been a lingering question about which one to do first, and this is one of the first trials to address that question, randomizing 300 patients to either first chemotherapy, FOLFOX, followed by chemoradiation, then surgery, or start with chemoradiation and then followed by FOLFOX, then surgery. And what they found was that there was improvement in toxicity with starting with radiation first, as well as higher compliance rates. And then most importantly, though, there was a higher pathologic complete response rate of 25% versus 17%. In an update in 2022, no difference in any of the clinical endpoints was shown. So the TNT summary here, kind of reviewing the trials that it showed, you can see that in general there was an improvement in most disease outcomes, suggesting that TNT with long course radiotherapy likely optimizes local control, distant metastases with chemoradiation and chemotherapy, respectively. So this has been our standard of care. I assume that's been the case also in Taiwan. I remember talking with some folks a few years ago, and I think it was still not quite fully adopted, but I would assume that it's probably adopted by now. So that's where we are with that, and so TNT now has become sort of our first treatment approach with anyone with locally advanced rectal cancer. It's interesting, though, about non-operative management, because that is now sort of the next sort of kind of area where I think there's going to be a lot of interesting developments. Currently, this has become a major treatment option for us in the United States, and I'd be curious to know how well it's been adopted in other areas. But non-operative management means omitting the surgery, and the reason why is because approximately 15 to 28% of patients receiving neoadjuvant chemoradiation will have a pathologic complete response. Radical surgery is associated with a lot of bowel and sexual dysfunction. LAR syndrome, we know many patients often have lifelong changes in their bowel function. And many patients come in and they really they very much desire organ preservation. They do not want to have an APR, they do not want to have a lifelong colostomy. So that's been a driving force, particularly in the United States, and been a particular challenge for us. Now, the first paper that described non-operative management was from Brazil by Habergama, and there's been a lot of studies ever since really supporting non-operative management as a viable option. MSK, this one is probably one of the more modern studies, but this is one that I think has really kind of set the stage or really set the baseline for what we compare to. But this was 113 patients at a US institution, of course. Many of the other ones came from Europe or from South America. But these are patients, it's a mixed bag because it's retrospective, but treated with chemoradiation with 5-FU or capecitabine. Some of them received total neoadjuvant therapy as well, because that was also a treatment developed and pioneered at MSK. And the patients were followed, and the patients in the watch and wait arm the group tended to be older, with lower tumors and with either induction or consolidative chemotherapy. And the main thing they found was that the local regrowth rate was about a little over 20%, 21%. But the overall rectal preservation rate was 82%. And the median time to local recurrence was 11 months, so most of them recurred or regrew within one year, the vast majority, and almost all of them, about 95 or 98% of them will regrow within 2 years. All 22 patients with local regrowth were detected on routine surveillance, and they were treated and salvaged surgically. And so of these 22 failures, 20 out of 22 were free of pelvic progression at last follow-up. And you can see that if you take the best of the best pathologic complete response group here, very, very good survivals. But if you look at the watch and wait group, you can see there's still very comparable to what historical unselected survival rates would be for patients. And most importantly, the disease-specific survival was very comparable between watch and wait versus the very best of the patients managed with surgery. The one scary thing, or the one thing I think of concern that came out, of course, is that if you do experience a local regrowth, the rate of developing distant metastases was actually quite high at 36% versus 1%. So this certainly suggests that these patients are at much higher risk and probably need additional therapy. Like I said, many places have been adopting watch and wait, and so there's this international watch and wait database that comprised mostly European centers, also down in South America and a few North American centers. And they pooled their data to develop this registry, and now they wound up getting about 880 patients that had a clinical complete response managed with watch and wait. Most of them were clinical T2, T3, about a third were clinical N1, and most of them were managed with standard long-course chemoradiation. The 2-year local regrowth rate was about 25%, 2/3 within the first year. The vast majority of them within the bowel wall. And for those with regrowth, the surgical data was 78% required a total mesorectal excision. The 3-year distant metastases rate was 8%, but those that developed a local regrowth, again, a concerning 18% developed distant metastases. But overall, disease-specific survival and overall survival compare very, very favorably to historic data. Now, this is my favorite trial. I think this is the one that really sets the stage and I think argues a lot for what I think the best treatment option is for patients. This is the OPRA trial led by Jose Garcia Aguilar at MSK, and this was really testing, the main question was, which should go first, chemo or chemoradiation? So they randomized patients to either induction chemotherapy followed by standard long-course chemoradiation, or the opposite, chemoradiation first followed by chemotherapy. They were then restaged, and if patients had a clinical complete response, they were given the option of watch and wait, and for those that were not, they underwent surgery. So this is the demographics for the patients, but most importantly here, if you look at time to regrowth, you can see that those that received chemoradiation first had a reduced rate of regrowth, as well as an improved total mesorectal excision-free survival. And they also reported that the organ preservation rate was higher with chemoradiation first, followed then by chemotherapy. Overall, 74% of patients were offered watch and wait, no difference between the groups. But ultimately, again, there was improvement in the time to regrowth with chemoradiation first. No difference, though, however, in any of the other clinical endpoints. So this is important just because I think it shows that sequence probably does matter, and it makes more sense to start with a local therapy if your goal is for organ preservation. This is the OPERA trial. It's not to be confused with OPERA. It's one-letter difference, but just know that there is a slight difference. But this was another, it really just highlights another strategy for how you can actually improve on the non-operative management rate. It actually uses intracavitary brachytherapy, which is basically either, you could either use external beam boost, but what they really used was this orthovoltage boost of 90 gray and 3 fractions. So very superficial radiation to boost that remaining residual lesion. And ultimately, they just showed that at the 5-year update of the OPERA trial, that patients that were treated with this very high dose brachytherapy boost had improvements in their outcome, and it was very well tolerated. So overall, increasing adoption of watch and wait, as mentioned, you can see that as the improvement in pathological complete response has increased over the last 1 to 2 decades, it has really sort of laid the foundation for the increased adoption of watch and wait, which is this blue dot. And you can see the dates go up to about 2020, but I think those of us that treat rectal cancer, I think we see this very routinely now done in our clinics. At tumor boards, pretty much this has become our standard recommendation for any patients with locally advanced disease now. So this was a study really just saying, how can we better select patients for, perhaps there are ways that we can do a better job of now predicting a complete response. and these are patients that were really using this quantification of intratumoral CD3 and CD8 T cells from the biopsy, and then segregated them into immune score high, intermediate, and low. And they found that this was a way that you could potentially stratify patients in terms of recurrence-free survival and disease-free survival, and this potentially could be a way that you could then further help with distinguishing patients who may have a good response. So the summary for organ preservation is 3-year local control, a local regrowth rate would be between about 20 to 38%, most recurrences within 1 year, the vast majority within 2, about 78% up to 100% of patients that developed a local regrowth were managed with salvage surgery. There are some concerns about distant metastases for those that regrow. And so again, I think the role of chemotherapy can certainly be discussed. I think if pursuing watch and wait, the important thing is that you must have very, very compliant patients who are willing to undergo very, very thorough and very close surveillance. And I think if you put all the data together, chemo, radiation first, followed by chemo, seems to be the preferred sequence. And then finally, chemotherapy alone or systemic therapy alone. This is the other kind of raging topic, I think, right now happening in the United States and elsewhere. Really all of this is driven by one trial that came out 2 years ago. This is the Prospect trial, which was published in New England Journal in 2023. This was a multi-center phase 3 randomized trial of about 1,200 patients with what we would consider intermediate risk disease. T2N1, T3N0 to N1. So no T4 tumors, no N2 tumors, and no low-lying tumors. Patients all had to be eligible for organ-preserving surgery. And they were all MRI staged. Patients were treated to either the experimental arm of chemotherapy alone, 6 cycles of modified FOLFOX, and if they had a good response, which is meaning less than up to at least a 20% clinical response on imaging, they underwent surgery, followed then by more chemo, and then the standard arm was chemo, radiation, followed by TME, and then 8 cycles of adjuvant chemo. And this was a non-inferiority study, and it basically met the threshold for non-inferiority. No difference in disease-free survival for patients managed with chemotherapy alone versus chemoradiation. And if you look at overall survival, again, the curves are nearly identical, but more importantly, I think for us, you can see there's actually no significant difference in local recurrence between the 2 arms. So this study, of course, raised a lot of discussion amongst the community about whether chemotherapy alone is a sufficient treatment option for these patients. Real quick here, just showing toxicity, I'm sorry, not toxicity, but R0 resection rate was no different between the 2 groups, and importantly, the pathologic complete response rate was also very similar. This is the other, I think, kind of real compelling data to suggest why chemotherapy may be the standard of care. If you look at this, they did a parallel publication looking at quality of life, and you can see bowel function favored chemotherapy alone, but more importantly, I think the sexual function with men and women, there was clearly a statistical significantly improvement or benefit by avoiding radiation. So the conclusions from this are that FOLFOX was non-inferior to chemoradiation with respect to disease-free survival, similar rates of path-CR, overall survival, and freedom from local recurrence. The caveat, though, is that these were highly selected patients. These were not locally advanced high-risk patients. They were mostly T2, T3. 90% did have clinical T3 disease. But remember, T4 and N2 were excluded. And remember that the chemoradiation was not part of TNT, which is not the standard of care anymore. So it's hard to extrapolate this to current practices, and most importantly, it's hard to extrapolate this to watch and wait, because if watch and wait has now become sort of the standard of care, then we would not consider chemotherapy alone as an acceptable treatment option. But I think we're more encouraging where I think systemic therapy alone could be used is now with the use of immune checkpoint inhibition. There's been a few studies now really suggesting that for a subset of patients, those with MSI high, microsatellite instability, or with mismatch repair, these two diseases can be actually handled quite well with immune checkpoint inhibition. This is data from colon cancer. This is the niche trial that actually just got published at the end of last year. But these patients were managed with, were treated to ipi-nivo, neoadjuvantly, followed then by surgery for locally advanced mismatch repair deficient colon cancer. And you can see that there was a very high rate of major response, about 95%, with 68%, over 2/3 of patients had a complete pathologic response with ipi-nivo alone. And if you look over here at the Checkmate 8HW trial, this was randomizing patients to either ipi or ipi-nivo, nivo versus nivo-ipi. You can see that the combination immune checkpoint inhibition showed improved survival for patients with metastatic colorectal cancer. So in the rectal cancer world, really the first real trial that really suggests that immune checkpoint inhibition could be sufficient neoadjuvant treatment is the SURSEC study from New England Journal. 12 patients treated with dostarlimab had a 100% clinical complete response and was managed without surgery. And this was followed by 2 other studies which also showed very high encouraging pathologic and clinical complete response rates. So now the ASTRO clinical practice guidelines that were published last year make the recommendation that for patients with mismatch repair deficient or MS-high rectal cancer, omission of neoadjuvant radiation is recommended after a clinical complete response to upfront treatment with immune checkpoint inhibitors. So overall conclusions are total neoadjuvant therapy is the standard of care for locally advanced rectal cancer. Radiation first unless high risk of systemic disease. That's been our preference. Short course radiation is not recommended. Non-operative management is reasonable to offer to patients with clinical complete response. Patients must be willing to undergo close surveillance, however. So if patients are not, I would not recommend non-operative therapy. Neoadjuvant chemotherapy alone is an acceptable standard of care for intermediate risk rectal cancer patients who have a good response, and immune checkpoint inhibition alone is sufficient for MSI-high or mismatch repair deficient rectal cancer with or without surgery for clinical complete responders. I think this is an area that still needs to be worked out about the role of surgery, but it's pretty clear that radiation is not needed necessarily in this group of patients. So I just want to switch gears now to liver cancer because that's been kind of where more of my specialty has been, but this is kind of an area that's very near and dear to my heart. So background. Hepatocellular cancer, 6th most common cancer worldwide, 905,000 new cases, with 830 deaths each year. That's data from 2020. The vast majority of patients have unresectable disease, and because of that, there's a number of non-surgical therapies that have been developed. And of course, some of the newer players now, histotripsy is a new player to the field that was actually developed at the University of Michigan, but will mainly focus on the role of external beam radiation and SBRT. So really what it comes down to is how does radiation work compared to other modalities? This is older data, but this is retrospective data, retrospective study from the University of Michigan comparing basically SBRT versus chemoembolization. You can see that there's a dramatic improvement in local control because of the ablative effect of SBRT, also improvement in liver progression-free survival if you treat a patient with SBRT versus chemoembolization. In a randomized trial of protons, this was done by the Loma Linda group. They found very similar findings. You can see local control nearly doubled with proton radiation, not SBRT, versus chemoembolization, with a near improvement in progression-free survival. Recently, there was the Trendy trial. This looked at patients treated with chemoembolization versus SBRT, and you can see, again, very similar results. Very high rate of local control with SBRT, time to progression, and, but not quite with overall survival. So we know that SBRT is better than chemoembolization. That's not a big surprise. But how does it compare to other ablative therapies? The University of Michigan also published this retrospective study looking at SBRT versus RFA. Their main finding was that for the overall group, SBRT was better than radiofrequency ablation. But when you broke it out by tumor size, SBRT, there was actually no difference between the two modalities if the tumors were less than 2 centimeters. However, if they were greater than 2 centimeters, SBRT had improved local control. So interestingly, just I think at the end of last year, there was this trial that was published out of China. And they basically asked the exact same question in a randomized trial this time. And what they found was that overall, local control or local progression-free survival was improved with SBRT versus radiofrequency ablation. But interestingly, they found the opposite of what the other studies showed. They actually showed that for tumors that were less than 2 centimeters, SBRT actually had improved outcome. So kind of the opposite of that. And this makes a little less intuitive sense because we know local failure is higher for larger tumors treated with ablation, so it's hard to quite explain why there is that difference. But I think it's just another kind of piece of data that we use now to really establish that SBRT is a standard of care treatment option. So really what we focus on is we know SBRT works. It's the standard of care. We all do it. I know many folks in Taiwan do it. And I think the challenge that we have the most is really how do we handle liver tolerance, right? Because these are patients that have had a lot of prior therapy. They have cirrhotic disease, cirrhotic livers. Their tolerance is low. And many times these patients have to come back to us for more SBRT or more radiation. So each time we always have to wonder how much more radiation can we give. So really it's important to understand our models for liver tolerance and how do we kind of account for that. So again, for more background, really there's kind of two major ways I think that we think about liver toxicity. There's sort of this more like NTCP method where you convert, you use this mathematical modeling to convert whole organ tolerance doses into estimates of complication based on this partial volume radiation that we do. And so, it's a little bit more complex and more nuanced, but it has been very robust in the data since it was published. It works very well in the clinical setting. The critical volume model, that's the one I think that many people are familiar with. This one makes more intuitive sense, and it's much easier for us to apply because it basically just says that if you can preserve a critical amount of volume of your liver from getting above an ablative dose, then the patient's liver should do well. And that was kind of what was first used in the early days of SBRT. And this was primarily started with metastatic patients, so patients that were non-cirrhotic. This has actually served us very well, and the number of trials have used this metric and really found very few to really no events of toxicity. The one that did was actually this Mendez-Romero one from 2006, but one of the early ones, but they found that there were 2 cases of grade 3 toxicity, and interestingly, they did not meet the 700 cc spared from 15 gray. Both patients actually had below 700 cc. So certainly that, that helps solidify this dose constraint as what we use today. If you were to use an NTCP model, NTCP is much more related to mean liver dose. So mean liver dose has been kind of the main surrogate that we use when we try to estimate NTCP. And you can see that there's a very good correlation between mean liver dose and the risk of radiation-induced liver disease. And this has been primarily used for hepatocellular carcinoma, for patients that are cirrhotic. And so, for instance, in Laura Dawson's NRG 1112 trial, she actually allowed a customization or choosing of the dose based on the risk of toxicity using the mean liver dose. So now that we know this, and I think for most of us that treat liver tumors, we sort of have our own method, we have our own way of accounting for toxicity, and we have that down. The question is how can we kind of further push the envelope or expand our horizon, expand the indications for radiation for patients beyond this comfort zone? And so many people have looked at different ways using technology, and so one of those is online adaptive radiotherapy. I think you've heard some of this already, but the advantages of things like MR-Linac, this has been kind of one of the main technologies that has been used, is we have the ability to see varied anatomical motion, accurate soft tissue, accurate gating. On-table adaptation is kind of the main function, the fact that you can alter the plan based on the anatomy for that particular day. And then you have onboard functional imaging to ensure that you're hitting the tumor correctly, as well as to make sure that you are accounting for any anatomic changes. So current methods are you basically will get a scan, an MR scan for that day if you were to use an MR-Linac, and you'll basically estimate what you think the risk of toxicity would be if you use the predicted plan or the original plan. And if you don't like it, then you would replan it and come up with an adaptive plan. So here's an example. You can see that's your target, and you can see the anatomy for that particular day. This piece of bowel moves into your target, so you would not want to offer the original plan. And so you could then modify that plan for that day to purposely try to stay off of that loop of bowel. And so for this DVH, you could see if you were to have given the non-adaptive plan, you would have underdosed the PTV, and you would have probably given more dose to your small bowel. So you can then adapt the plan to be able to cover your PTV better, as well as to spare your small bowel. So this technique has been used for a number of upper GI cancers. Pancreas is one major one, but also for liver. And this is a study that came out recently from the Washington University group, who have been leaders in MR-Linac. And they looked at the retrospective data for patients with HCC, cholangiocarcinoma, or the mix. About 100 patients treated with 50 gray and 5 fractions, and about 54% of these patients, more than half, their PTVs were within 1 centimeter of the duodenum, so the small bowel. So that would have been normally a dose limiting organ. And so about almost the same proportion of patients had their plans adapted online using these dose constraints. And ultimately what they found, you can see that the local control rates were extremely high, local failure rate at less than 10% for both the HCC group as well as for the cholangiocarcinoma group. So good outcome, excellent local control. But importantly, what they showed was that if you look at acute and late toxicity, you can see the overall toxicity rates were very low. So it shows that you can still give very high doses, 50 gray and 5, with the adaptive technology, and you can achieve good local control without increasing toxicity. And so this is just kind of a series of studies that have published on MR-Linac. You can see overall very high local control rates and very low toxicity rates. But there are limitations to real-time adaptation or online adaptive approach. Organ motion is possible during the replanning process. If anyone's ever seen an adaptive process, it can take 45 minutes to an hour, and while you're contouring and replanning. So if there's motion that happened during that time, you won't be able to account for that. Obviously, everything relies on a predicted dose to the organs. You're relying on putting this old plan onto a new scan and making decisions off of that. You're not able to know what was the actual dose delivered to the organs. And then I think for more practical purposes, MR-Linac systems are expensive and time-consuming. So I think more to be seen about the role of MR-Linac. I don't know how many folks have experience with that here. I heard there was one MR-Linac in Taiwan, but it'd be nice to see kind of how that data compares and if the indications will expand. So that's online adaptive radiotherapy. There is biomarker-based adaptation, and this is something that University of Michigan has kind of developed and become pretty well known for. This is actually not my work, but work from my colleagues. But again, we know that patients treated with HCC, because they have cirrhosis, they have a weakened liver and a decreased tolerance to radiation. This is one of the early studies looking at SBRT for patients from Princess Margaret. High local control rates, 87% in 1 year, but 30% had grade 3 or higher toxicity, with 7 of those being deaths thought to be likely related to treatment. So obviously, we would want to try to get these numbers down, and again, that comes with better understanding of liver tolerance. The limitations of this NTCP model is that we use the volume of the liver, of the normal liver. The problem is, this is useful when that liver function is normal, but remember, these are HCC patients, so they have underlying cirrhosis, so they have cancer as well, and so both of these present problems that would reduce the tolerance of the liver. So how can we better estimate the liver function? Well, you can measure it pre-treatment, and if you can somehow measure it pre-treatment, then you could probably try to measure it during treatment, very similar to some of the work that you heard from Nancy Lee before. If you can do some sort of mid-treatment assessment, either through efficacy or in this case with toxicity and function, perhaps we can improve the outcome for these patients. So how can we do that? Well, the investigators at Michigan years ago, they decided to take this compound IC green, indocyanine green, which is rapidly bound to plasma protein and is pretty much excluded almost exclusively from the bile system. So the liver processes it, so it's a way to measure the function of the liver. And so this has been used by Japanese surgeons, historically to determine the safety for liver resection. And so changes in indocyanine green or ICG retention can actually happen, can take about a month or so, but it can correlate with subsequent liver injury. So can we use this and apply it for how we tailor radiation doses for patients? Why do we treat all patients as if they're going to have as much toxicity from treatment as the worst 5% of those patients? So this is a way that, again, for precision medicine and adapting treatment based on risk. So the original protocol, they took patients with HCC, thought to be at risk for liver toxicity. They would do a pre-treatment ICG assessment, measure the retention rate of the ICG, give 3 treatments of SBRT, and then give them a 1-month break. That's pretty radical because, you know, we generally don't like treatment breaks, but for them, they felt that it was worth it to wait a month and then repeat that ICG assessment. And if there was signs of, if the retention of the ICG went up, that was a sign that the liver function was getting worse. And so if that were the case, then they would not proceed with the remaining fractions of SBRT. However, if the liver function was preserved, then they would then deliver the subsequent 2 fractions of SBRT. So with these patients, they had about, in this protocol, they started with, most patients had child A, but there were about a quarter of patients had child B. Median tumor size was 3 centimeters. And ultimately what they found was that they were able to deliver a mean liver dose of 13 gray, and the median dose used was 49 gray, generally in 5 fractions. So they were able to preserve that dose quite well with this approach. But most importantly, I think everyone's wondering, did the 1-month break impact local control? And the answer is it doesn't seem like it did, right? Because 1-year local control was 99%, 2-year local control was 95%. So very, very good local control, even despite the 1-month break. Overall survival was 67% at 1 year, 36% at 2 years, but local control was not predictive of overall survival. Average of 2 prior treatments. And in terms of toxicity, you can see that overall it was quite tolerable. About 20% of patients had a 1-point Child-Pugh score increase, which we would not score as a toxicity, but about 10% of patients had a 2-point Child-Pugh score increase. So that would have been considered a toxicity. But even at 10%, for a local control rate of 95% at 2 years, that was seen as very favorable. They did some modeling work to show that the adaptive process, by adapting the dose, they were able to change the predicted risk of liver function. So by doing so, you would have predicted that their liver function or their ICG green retention would have worsened, but by adapting the dose, they were able to bend that curve. And then, of course, what they showed was that did the break matter? And so they looked retrospectively at their patients, those that received a break and those that didn't. Ultimately, they showed that there was no difference between the curves, between those with break versus no break. So the question is ICG, no one really uses it. It's very specific to Michigan. How do we make it more broad and generalizable? So the ALB score, you know, this is a more common measure now that we use for liver function. And ALB is basically made up of albumin and bilirubin, 2 lab studies that you can use that are very easy to get. And this was first kind of validated in a very large pooled international database showing that ALB score was actually better than Child-Pugh score at predicting liver function and survival with HCC. And investigators showed that there's a very good correlation between ICG retention and ALB score. So very quickly, ALB replaced ICG. And they were able to show that patients that had a low or a very negative ALB, which is good, and they had less than a negative 0.31 change, which is also good. So if they had a good baseline function based on ALB and there was minimal change, no one developed toxicity. For those that developed a change of greater than 0.66, all of those patients developed toxicity. So most recently, we reviewed our patients and we compared this cohort of patients with another group from Princess Margaret who did not have adaptive treatment. And they wanted to compare local control and overall survival as well as toxicity. And you can see that between the 2 groups, standard SBRT versus adaptive, no difference in local control, no difference in overall survival. When you look at toxicity, there was a significant improvement in toxicity. So ultimately, they concluded similar local control with less toxicity with adaptive radiation. So, you know, this is obviously very exciting. It's become our standard of care, and we certainly, you know, advocate for this approach. You know, what would be the next steps, you know, to how do we can implement this further? We can improve our models. Obviously, can we improve early predictors of tumor response, improve predictions of toxicity? And more importantly, can we use this as a way to make better predictions of patients and how we treat them? You know, utility of treatment versus maximum safe dose. This is a concept that we're playing with where, you know, you can sort of model them based on outcome and toxicity. So progression, no or yes, or liver toxicity, no or yes. You can really only get one of, you know, there's only 2 options, right, for each one. And so you want to basically come up with this concept of utility. You know, what's better? Is it better to have, you know, no progression but have toxicity? Is it better to not have toxicity but potential for progression? And so investigators have been developing this way of trying to distinguish that by using the utility scores. We all agree that no toxicity and no progression would be the best, so that's given a score of 100. Having toxicity without control would be a 0, and then you can kind of modulate what you think and how you might modulate these different outcomes. And by doing so, we developed a model which helps us to basically decide whether or not we can treat a patient. And so we would input some of these numbers, total number of fractions, dose per fraction, what is the physical mean liver dose from the plan, what's their baseline child Pew or ALBI score, and eventually it'll spit out this output that says this should be safe to treat. The 1-year risk of local progression would be 5% with a corresponding toxicity of 11%. So you look at that and decide, is this worth proceeding with this dose? And that's been the model that we've been tinkering with and trying to improve upon. And I think it's actually been quite useful in the clinic. And then the last, and then the future steps, of course, we'd like to develop a simple-to-use app. And we now consider split-course adaptive radiotherapy for all high-risk patients, and we'd love to explore this in a phase 3 trial. And the last thing to talk about is how can we adapt dose with multimodality therapy. And so this is another protocol that Michigan has pioneered, and we're in the middle of enrolling patients. But the concept is, can we combine modalities with another very popular and very common treatment option, which is Y90, radioembolization. And for those that don't know about this, this is basically internal, they call it selective internal radiation therapy. You basically inject these small beads or glass beads that are attached to yttrium-90, which is a beta emitter. This has been approved for many years now. And you basically inject it intraarterially into the tumor, and you deliver very high doses that way. However, it's important to note that the limitations of this are that the dose delivered is dependent on the arterial perfusion. Lobar treatments can underdose the targets if you try to treat a large area, a whole lobe, and you could potentially underdose the target, which could lead to the risk of local failure. So the background here is that Y90, it's a selective with limited dose to surrounding normal tissue. It's possible to get heterogeneous coverage, and you can actually correlate pre and post. You can look at dosimetry, but the problem is that the correlation between pre and post Y90 dosimetry is very poor. SBRT, of course, we're all familiar with. This is non-invasive. You can get very homogeneous dose distribution, but it's limited because we cannot treat widespread multifocal disease. So can we perhaps combine these approaches to further improve outcome? And we know that brachytherapy and external beam is well established as combination therapy for other disease sites. There are some studies that have published on outcomes with Y90 with SBRT with no major toxicities reported. Time between therapies is relatively long, and the combined doses of therapies are not accounted for in treatment planning. So the idea is, can we personalize the dosimetry for these patients? Give them Y90. Is there a way that we can alter or adapt the dose for these patients based on the dosimetry that we get? So again, pre-Y90 dosimetry is primarily used as we try to basically decide how much dose to give, but I think where the real potential is in post-Y90 dosimetry. And there are a number of ways that you can do it, but the one that we prefer is to use post-Y90 PET scan. Y90 does emit a very low, a small amount of positrons, so you can actually pick that up on a PET scan, and so you can actually use that then to calculate the dosimetry of the tumor. So how can we act on this post-treatment dosimetry? So a hypothesis of a protocol that was open was liver tumors that are underdosed by initial treatment with Y90 can be safely boosted with SBRT. And so they opened a single-arm study where the primary objective was to obtain preliminary estimates of toxicity with a combination of therapy. So the endpoints would be liver decompensation. Secondary endpoints, of course, are CT-CAE grade 3 toxicity or ALBI change. So the protocol, patients will receive Y90. They will get post-Y90 PET, and then basically they will look at the dosimetry and look at the mean dose of the tumor. So was the mean dose delivered to the tumor less than 290 gray? This dose came about from a previous analysis showing that the tumor control probability was significantly lower if the mean dose was less than 290. So if the answer is no, then if the answer was no, or the tumor is the tumor is greater than 4 centimeter, then you would not give SBRT. However, as well is if the patients develop liver toxicity, you would not proceed with SBRT. But if the patient Y90 dose was less than 290 mean dose to the tumor, and they did not have toxicity, you would then proceed to the second phase of treatment, which is SBRT. And what you would do is you would then simulate the patient, you would draw your target volumes, and then you would subtract out the areas that received more than 70 gray. And the reason that was chosen was from another analysis showing that the D90 for the tumor was a significant correlative to tumor control. So here's the workflow. Here you go. Imagine two tumors in the right lobe, one small and one large. You plan a dose, you deliver treatment. This tumor has a mean dose less than 290. This one is greater than 290, so this is not eligible. This would be considered a responder. This would be considered a non-responder. You would then simulate the patient for SBRT. You would then only treat the area that received less than 70 gray, and then you would proceed with treatment. And I have an example to show you. I probably want to move along quickly here. So here's an example of a patient, two large tumors, one here, and then one here and down in segment 6. So patient underwent SBRT. You can see this was received adequate Y90, whereas you can see the very heterogeneous uptake here. So we then transfer that dose map onto the CT scan. We contour, and basically you contour out your target, and then you subtract out the area that received more than 70 gray, leaving only the area that received less than 70 gray to be treated. So that's the purple. And then we plan to give 6 gray times 5, and that's what the plan looked like. And then ultimately, 2 years later, patient is doing well with good control. So, this is an exciting trial. We're continuing to enroll. We've enrolled 19. I think these numbers are actually better now. Outstanding challenges, of course, are decompensation prior to SBRT, image registration, and combined dosimetry are problems. So this is a work, obviously, of a lot of folks. And I just want to quickly wrap up and say SBRT is a highly effective curative therapy for HCC patients with good liver function. It's non-invasive, more effective than RFA. Toxicity models and tumor control are improved by using response-based therapy, particularly for patients with large tumors and poor liver function. ALBI can replace ICG as a marker for liver function, and there are many emerging opportunities to adapt treatment based on reducing toxicity. So again, just want to acknowledge folks that I've worked with, and thank you. And again, thank you very much for allowing me to be here to talk. There are 3 minutes for questions. Yeah. I think there's a microphone right behind you.
I would like to ask, is there any role of radiotherapy in the adjuvant setting of hepatocellular carcinoma? Because I know there's a phase 2 trial in China that said that adjuvant SBRT may be useful in the high-risk HCC. How about your opinion? Thank you.
Sorry, can you ask? So the question was SBRT in what setting? In the post-op?
Yes, in the adjuvant setting.
Yeah, I mean, we usually don't do it in the postoperative setting except like in positive margins or residual disease. Is that kind of the situation you're talking about?
Yes, yes.
Yeah, I mean, that's not been our practice. I think that it certainly is an area to be explored. Positive margins, and generally they won't take them to surgery if there is a risk of residual disease or positive margins. But I'm not really familiar with them. I think most people would think about using adjuvant immune therapy or something else usually in those situations. So it's not been an area that's been strongly explored, I guess, in the United States. Sure. One more minute or less. Yes, please.
Yes. Is this really important to minus the SIRT dose, then give SBRT? I don't think it's really necessary.
It's a great point. I will admit that so the protocol, it's a feasibility protocol to see if it can work. I think it's partly done because, again, the tumors you have are usually pretty large. And I think there's a general concern that, you know, liver tolerance and exposure to radiation. So anything you can do to reduce the amount of radiation to the target is better. You can see how large that target was. It's easier to treat a portion of that than the entire. But I think that, you know, in the future, if this is safe, then I think we can be more aggressive and perhaps skip that step. But I think those are areas that we need to explore once we get data from this trial. But it's a great question. I agree. It's a good question. Okay, well, it's 12 o'clock. Thank you very much.